Hi, I'm Jim Wood. I'm chairman of Wood Communications Group, a strategic communications firm based out of Madison, Wisconsin. I serve as strategic counsel to the Concerned Actuaries Group. And we're going to break this program into kind of three sections. I want to talk about disconnects in terms of the issues that the conversation raised. And then we'd like to talk about why these disconnects exist, in your opinion, so we can dig down a little bit into that, and then we'll turn it back to Mark and Ron to talk a little bit more about the model and the next program, which is holistic analysis. But let me start, if I could, then with this concept of disconnects. The very first program we did was on context. And if you've watched it, you know that our participants talked about symptoms. The disconnect piece is an attempt to understand and talk about why those symptoms exist. Okay, it's all well and good to look at it and sympathize with the people who are, whether they're providers or patients or whatever. But ultimately, if you want to fix something, you've got to take a look at what the major disconnects are that are producing those symptoms. And what we're hoping you folks will help us do this morning and comment on is your take on whether our take is correct, that cost versus revenues, for example, is a systemic problem that generates specific kinds of issues or whatever. So let me start there. Let's start with the four that the model is based upon, and then we'll come around to the consumers and information and legislative intent piece. But I'd ask Mark and or Ron to just give you a 1 to 2 minute summary of each of these as we started. And let's start with the cost versus revenues piece. Mark, you want to go first?
In our work, we have identified not only actuarial principles that we think are problematic, such as risk classification, moral hazard, et cetera, but also economic principles, such as supply demand, accounting principles, which is a huge area, such as matching expenditures versus revenues. And in this area of cost versus revenues, which really is, if you think about what's going on today, not just in healthcare, but with what's going on with the infrastructure bill, with the additional $3.5 trillion bill, wherever that stands, the fact that the accounting that's being done or not actually being done, and the whole lack of risk management, which is another actuarial principle, is really a serious problem. And we don't have any accounting. And now we have these proposals coming forward, that, well, we can get the $3.5 trillion down because we won't start the program that we want to put in, such as expanding Medicare into dental and vision and so forth, till year 8 or year 9 out of a 10-year window. So that just defies what actuaries think about in terms of present value. So I'll stop there and turn it to Ron for comments.
I think in a previous program, we talked a lot about a concept called cost shifting, which I think fits here as well, whereby the government programs really are doing a lot of price control type activity. And in effect, you get sort of a balanced billing then that goes to private paying patients, whether they're insured or paying out of their own pocket. I came across a interesting graph a couple of weeks ago. I think it was a Kaiser Family Foundation analysis of some CMS data. But it was very simple. All it was 3 lines on a graph, and it was looking at the growth in the cost per enrollee, depending on how you were getting your healthcare coverage. The years 2008 to 2019, the cost per enrollee grew 51% for privately insured individuals, 26% over that same time for persons in Medicare, and 16% for Medicaid. So you can see the price controls having their effect, taking their traction in Medicaid and Medicare. And what happens is then furthering the cost problems for privately paying individuals, sort of a phantom or shadow pricing taxing mechanism almost.
So I might just pick up on what Ron said, just to add. So in our modeling, which we're going to talk about in much more depth in the next webinar, if you think about how price controls work, so they change reimbursements, and then what happens? Well, obviously that can affect access. And we know we have shortages of doctors in some areas and nurses in many areas and other medical professionals. So that affects the access. Of course, then lack of access affects the health status of the population. And as the health status of the population gets worse, then that affects your economic output or your GDP. And those kinds of effects occur throughout the model. So it's when you start doing these things, there's lots of unintended consequences over time.
Abe, in the first webinar, you made the point that the cost of life insurance has been going down consistently, while the cost of health insurance has gone up. Do you have any sense about why that and how that relates to the cost versus revenues piece?
Well, I think, you know, a number of years ago, I kind of made the decision that I wasn't going to frustrate myself by dealing with things where you're always going uphill, because there are certain businesses where you're always trying to go uphill, and this is one of them. And I think the answer is simple. Now, there are cost increases on the health side because continuing more sophisticated treatment mechanisms get developed. But in my mind, and this is where, you know, I'm from a different field. On the life insurance side, it's basically a market mechanism. You have much less regulation than you have on the health insurance side. And for the most part, the person that is getting the coverage is the person that's buying the coverage. Because I always think the basic challenge that we have on the health insurance side is that we use an approach where you go to a person that sells something and you and that person agree on what would be best for you to have. And then you send the bill to somebody else. And it might be the government, it might be the federal government under Medicare, it might be the state government under Medicaid, it might be your employer, if you have an employer paid plan. And you have many situations where you're told by the provider, well, you're covered for this, or this will only cost you this amount because somebody else is paying for it. And if we ever applied that sort of purchasing approach to transportation or food or anything, the costs would explode just like they do on the medical side. And the challenge in the going uphill that we have is that every attempt to deal with cost actually aggravates it further. Because the solution is that, you know, it's just too expensive for people, so let's pay for it for them. Let's pay their premiums for them, let's pay their deductibles for them. And you get further and further away from a market system. And so, you know, we'll be pulling our hair out if we're trying to really solve it. The only way you can solve it based on what we're currently doing now, in my opinion, is for the government to own the hospitals and treatment centers and the medical providers to be employees of the government and have the government impose its rules on them as it's trying to impose on everything else. Otherwise, it's just going to continue to go the way it is, and the cost will continue rising.
I think maybe to go off Gabe's comments, I've spent the last 18 years since I retired spending half of my year up in Canada. And Canada strictly regulates supply. And Canadians love it. And if somebody needs a hip replacement and they're told that they can't get their hip replacement for 15 months, and furthermore, they don't have any control over who's going to do the hip replacement. It might be somebody who's done 50 of them or someone who's done 5,000 of them. You have no say on it at all. It would not be acceptable to me, but Canadians love it and go along with it. And I think Canada has been very effective with regard to what they've done to it. And kind of a separate point, I don't know about the rest of you, but when they announced this new Alzheimer's treatment, I guess you could call it, it's not a cure, but a treatment for a mere $52,000 a year, it at least blew my mind that with our growing issue with Alzheimer's, and now you've got a supposed cure, or a treatment, which people aren't even sure if it's a treatment effective or not, but it's still going to be $52,000 a year. And that kind of pricing, I think, is all over the US medical system, and the medical system just keeps on bringing more of those sophisticated things on board.
I think both of you are exactly right in, a lot of the things that you have observed about the system, and what our problems are. And that's, one of the reasons I'm excited to be part of this effort to, look at a very rigorous model of the system so we can do a better job of understanding impacts of, whether it's a change to Medicare or, whatever else it is. We can look very holistically at not only impact to the healthcare system and the workforce and all of those details, but also just the wider economic impacts, because, that's really the crux of the issue, I think, is we don't have enough money because all of the money is coming from the same place. You can't separate the healthcare money. It's not like some magical, source of money that we can spend as much as we want, because it impacts, what we have available to spend in other places and what families and businesses have available to spend for their other needs. So I think this model is really important to helping us as a country get to a better place with being able to make better decisions for our healthcare policy.
On that note, Mark, I'm going to ask you to segue into the subsidy versus need discussion in terms of the disconnects.
Those are great comments. When you get to the subsidy versus need, society needs to do these risk transfers. And when the government gets involved, there's subsidies. And there's nothing wrong with that if we can create more value. But many times in Medicaid in particular, because it's just a cliff, either you get 100% benefit or you get zero. The incentive is for people not to earn more than $1 above that threshold, whatever that is, which varies, of course, by state, family size, et cetera. And so as we've done our modeling, we're seeing these serious questions, and we've actually split our coverage in our work into not only the level of coverage, but the health status of the population and their income and or assets. So there's a determination made as to what actually is their need and how much to subsidize it. If there's too much coverage, whether it's too much moral hazard, a lot of adverse selection, versus, and we still have a lot of people have inadequate coverage. So this is where the subsidy versus need came from, that our risk transfer subsidy systems there's too little, there's too much. And if we can get the right balance, we actually will get more value. As we get, for instance, too much, we start to get a lot of adverse selection. We start to get a lot of waste, fraud, abuse. And of course, the inadequate, there's a big problem because people delay their coverage, their treatments for cancer and other things. They get sicker.
Sort of a personal anecdote from a couple of weeks ago. So my wife and I were working with talking to an elderly family member, and she had very recently fallen, had to go through rehab. She'd gotten through rehab and was just sent back home. And she was really bemoaning to us that she couldn't get a walker. She really needs a walker. She couldn't get a walker. It's like, why can't you get a walker? And she said, it's not covered by Medicare. Well, first of all, that wasn't exactly true. We could, in that situation, help her get coverage if her doctor was willing to say she needed it, et cetera, et cetera. But that's not really even the point of my anecdote. It is, now she was reasonably well-to-do, but even set that aside, she had just months earlier given up driving and given up her car due to some eyesight issues. So prior to that, she had funded her car. She owned her own car. She paid for insurance. She paid for license plates, all the maintenance, all the gas, all the oil. None of that's on her expense budget anymore. And yet this walker, which we helped her do the research, it cost $229. She was of the mindset that if that's not covered, I can't get it. It's so extend that anecdote out. We've really created sort of this culture, this mindset that in healthcare, unlike, owning a home, unlike owning a car, unlike food and technology and everything else, in healthcare, I only can afford it if it's fully paid for. And so that's the kind of over subsidizing that I think, in a little microcosm is throughout our system a problem.
Let me follow up on that if I can, guys. So in the model, as I understand it, you have distinguished adequate versus inadequate versus disproportionate, what you call disproportionate, based upon household incomes. Is that right?
Yes.
Okay. And I guess I'd be interested in some input from the audience in terms of whether that is a sufficient base for making the decision, or there are other factors that we ought to be aware of that impact that. I mean, ultimately, the importance, because the model, the beta runs that you've done thus far, basically showed that either the changes, big changes being made like ACA or whatever, have not really had a big improvement on the disproportionate number or the adequate and inadequate numbers. And so I'm interested in whether people think household income does it, or we need to be looking at other factors.
Well, this is an area that we know needs a lot of research. So our current model does everything on a nationwide basis. We know that from state to state, and even from region and states, there's a very different cost of living level. There's different problems. So standpoint, we know that there needs to be a lot of work done in this area. This whole area of need, of what people need to help themselves. You have some people, of course, who can't help themselves, and versus disproportionate is a very, very different. We think it's an area that needs to be explored and considered, because one size fits all is can work great, but people have very different needs. Their needs change. Their incomes and assets change. Tough area.
Yeah, I just want to go off Ron's comment. Ron, I think you had an excellent example, and I think it highlights that there's a whole area which I'll at least title as mindset. And people, I don't think, realize that they fall into a mindset in the US with regard to medical treatment and so on. And I think that's something that needs to be spelled out better. And I think one of the issues in moving forward to try to get the United States healthcare in a, if you'll excuse me, in a healthy state, is to quantify the mindset issue by itself and start a program that addresses the mindset and how do you go about changing that mindset. I'm not sure, Mark, how that, if it all blends into the model, but I think it's not a trivial issue in looking at where our country is headed with regard to the overall cost of medical care. So I would make sure we don't dismiss it as part of what needs to be looked at here.
In the conversation, people talked about one of the disconnects being between consumers and information that they had. And the example that Ron raised, that Rod just referred to, and they gave kind of kicked off this idea that when she learned that it was only $229, that apparently still wasn't enough information to get her to change her mind. Okay, and so it's not just that the information you get is so complicated and 700 pages of how do you comply with Medicare or Medicaid or whatever else it may be. It is that you bring a mindset, as Rod and Bob Shapiro would, to it, so that you view, as Gail has suggested, information about health coverage differently than everything else. There is this, I don't know whether it's an entitlement view that says I'm getting paid by my employer, and that's a benefit that I get, or I'm Medicare or I'm Medicaid, and therefore I'm qualified, and therefore it ought to be covered. But I'd be interested in this question of, do we think that part of the disconnect is driven by the fact that consumers do not have enough information about what drives costs and how they impact the system?
Absolutely. That's a huge part of it. And my thinking, my studying of the issues indicates that part of the reason for this is that the way the incentives are structured and the way we perhaps overuse insurance and all of those things together that bring us to the system we currently have today, all of that leads to the complexity and the lack of transparency that is allowed to continue because people don't take the same view of buying healthcare or buying health insurance as they do the way that they think about buying other goods and services. So it's kind of this complicated, situation, this system that we have today. And it kind of defeats all of the other ways we think about and the ways that the providers have to behave in other parts of the economy because of all this complexity that's built into the system that has evolved over the past, 80 to 100 years.
As we kind of go down this, I never expected to speak at all during this session, but I will say that one of the things that's concerned me for years, and I'm afraid I don't know the exact number, but something like over half of medical care costs are incurred during people's last year of life. I don't know if any of you have any more updated thing, but whatever that number is, I think it's more than half. I'm afraid to say it. And performing hip replacements on a 92-year-old that's got multiple health issues is the kind of thing that just makes me nuts. And I know it eats into a huge amount of the overall medical cost and medical insurance cost. And I've always felt that people need to start to know those facts so that they can become intelligent consumers. And before they rant and rave about, my 92-year-old mother really needs that hip replacement, even though we know she's only going to last for 6 more months. Politically, it gets translated into being these death panels or whatever, but I think it's something that as a country we need to step up to and deal with if we're going to get our arms around the cost issue.
I'm going to keep pushing the segues here then, because let me link that conversation to the question of legislative intent versus actual performance and how all of that factors in. And let me make a controversial statement and see, knowing that I'm doing so, is part of the problem with the information consumer side of it, the fact that everybody is selling something while they're doing it, okay? So politicians are basically saying, I'm doing good things for constituents of need. Insurance companies then pursue the budgets that are generated by those subsidies that have been put out there or by the requirements of the opportunities of the expansion of eligibility. And somewhere in there, the benefit is not on managing, it is on providing. And then everything is around that process. Is that part of the issue here?
That's an interesting question, Jim, and it's something that I was thinking about as we're having this conversation. Because, when you go back to the life insurance side, life insurance really operates on an insurance model. And in the healthcare, we don't really have an insurance model for the most part. We have a prepaid prepaid healthcare approach rather than using really insurance principles. And that's a big part of the problem. And it's part of the mindset issue that was mentioned earlier. And we have prepaid healthcare, but without any cost controls, or very little cost controls, very little incentives to control the cost. And so you have the kinds of things like Rod was talking about. People get paid for doing procedures and they're going to do the procedures if they can get paid for doing the procedures. In fact, the fact that whatever the mechanism is that pays them is willing to pay them, that in their mind is endorsement that it's appropriate that they do the procedure. At one time, there was an attempt to control the costs and some incentive to do so. And Ron and Howard and Mark will know a lot more about this than I do, because I never practiced on the health insurance side. But I think back when HMOs were being used, they actually were starting to control costs, and costs were coming down. But you get this story about so-and-so being denied treatment because of the mean HMO, and the political side ends up taking control, and it moves to what we have now, where the political side wants to provide benefits for everybody, and they have a very difficult time dealing with the cost side of it, because they don't want the doctors and the hospitals lobbying against what they're trying to get through the legislature.
And just to chime in a little bit on this notion of the consumer, and sometimes people will say the problem in the healthcare system is that everybody is profit driven. And I would push back on that a little bit and just, urge us to think about how we behave in all other areas of our lives. The cost control that we have for other goods and services is, in the end, the consumer, which in the case of healthcare is the patient. So my view is it's not so much that, hospitals are profit driven or they can make money out of, end of life care and doing that knee replacement on somebody that, is only expected to, live for a short time. The problem is that the consumer, the patient, does not really have a say very much because they're not spending their own money at the point of care. In a lot of situations, virtually no care is paid for at the point of care. It's all paid for through insurance. And if you just think about primary care, which is one of the areas that I focus on in my research, with the, kind of the way that things have evolved, where, more and more routine services are insured and not paid for by the patient at the point of care. That's why we have so much price inflation, because the consumer is not sensitive to price when they're making those decisions. And that's, a discussion for another day. But I think this is, again, another example of how what we're trying to do and how we're trying to look holistically at the whole system is really powerful, because there is so much complexity to how all of this ties together.
What do you suppose the restaurant industry would look like today if, since World War II, every time you went to a restaurant, your employer paid for the meal except for a $10 or $20 copay, and it was left to you and the maitre d' to determine what it is that you wanted to have for dinner and how you wanted to be treated and what bottle of wine you wanted? It might be a little different today.
Let me follow up, if I can, on some of this. And there's a pushback that I think is fair. How is the consumer, the average citizen, supposed to make the decision at the point of purchase? Suppose you have it and you go into the hospital or you go into the doctor's office or whatever, and you say, goodness gracious, $800, that's outrageous. And the doc says back to you, well, which part of the treatment would you like me to not employ? These things come to me as a kind of prepackaged thing in terms of the cost of the drugs or the cost of the equipment or the cost of whatever. So I don't get to do it on a patient by patient basis. I'm not saying that we don't need point of purchase control somewhere in here on the part of the consumer, but the consumer tends to talk in monosyllabic words like yes and no. Cost too much? No, I can afford that. Okay, and that's not, you need more precision than that, don't you, when you're trying to take care of public health?
Yeah, just chiming in, because I think you're maybe going off of what I was just saying. My view is that the best thing to do is for patients to take back control of what's happening from the beginning of care, which is primary care. So once you are engaged with somebody that you're working directly with. It might be a direct primary care provider or somebody that just takes cash as you need to have primary care. And if they are, truly doing what primary care should be doing, and they're truly managing, your health and helping you all throughout the process, they will be involved, and help you navigate should you need specialty care or should you need surgery. So I think, if we could rethink and maybe change our mindset a little bit about how we initially engage with healthcare from the beginning, and that would dramatically change our mindset, and we would think about healthcare and health insurance the way we think about all other goods and services. And, when you need something done, if you're, assuming that you have time, which is the vast majority, or at least the majority of times, you do have a chance to plan ahead. You do have a chance to shop. Certainly there's times you get hit by a bus and you're in the emergency room. And of course, there are times when you can't plan and shop and, figure things out ahead of time a little bit, but most of the time you can. So, you can make those decisions as to, if you want the surgery in the big local academic medical center down the street and it's $30,000, or will they negotiate with you and, do something more reasonable for, say, $10,000? Or do you need to, maybe travel to a free market, direct pay surgery center and get something reasonable? And so you, again, as the consumer, are in control of that. And we can talk in a lot more detail about what kinds of options are available for helping you with those catastrophic costs in more of a direct pay system. But there are ways to, kind of address some of the cost issues besides just how are we going to tweak this program or ensure more kinds of services and require insurance to cover everything.
Yeah, I think Gail is exactly right. And just another quick example on the difficulty in medical care compared to everything else. To go back to restaurants, if you're deciding that you're going to go out and you want to have beef, you have a pretty good idea what a steak costs at the Capitol Grill. You have a pretty good idea what it's going to cost at the Outback, and you have a pretty good idea what a hamburger at McDonald's is going to cost. When it's healthcare, you have no idea what anything is going to cost. And so one thing the government's doing right now is trying to make people publish the cost is a good thing. But the problem will be, even if you get there and you put the consumer in charge, how do you put the consumer in charge? And it would be a better system if everybody had a spending account and then truly insurance, not paying first dollar, but insurance for when total costs get above a certain level, what we used to think was major medical type of coverage, and put the people in charge of their care so that when the doctor says, you should have this done, the person feels like I'm spending money out of my spending account. I'm going to decide whether I want to do that, whether I want to get it somewhere else, whether I want to have something else done. But that would be a big change from what we have right now.
We only have 10 minutes left, folks. This has been fascinating so far, but I want to touch on one other piece before we turn it back to Mark and Ron. And that's the question of, and again, in terms of disconnects, with so many different groups and people and organizations and institutions unhappy with what we have. I mean, American healthcare has been the third rail of American politics now for almost 3 decades, okay? It is so because it's very expensive. It is so because it doesn't work for everybody. It is so because everybody keeps telling you they're going to fix it and they don't, okay? Why is it that we can't seem to fix it? Powerful insurance companies, large hospital and healthcare provider systems, a national reach program, beneficiaries who are being represented by organized groups. Why haven't we fixed it thus far?
You're hinting on what is in my mind. The discussions you've had are wonderful, and the things you're talking about need to be addressed and approached and put together. But the big question is, how do we make a difference? What does it take to get these wonderful discussions past discussions and into meaningful discussion that lead to implementation. And it's very frustrating to me to see you guys do the wonderful things you've put together, and then just see the difficulty in having them have an impact on what's happening.
People who are making policy decisions, who for better or worse, as things exist in this country, are our legislators. They are elected officials at both the state and the national level. If they do not have the tools to be able to understand the impact of the decisions, you can't get where you need to go. And so it's not, for the Concerned Actuary Group, it's not just about having these conversations. It has been for over 2.5 years now, the development of this very, 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 in my personal opinion, model, is a comparative actuarial assessment model that actually can work in real time to let policymakers see what happens if they pursue a specific set of recommendations. We'll turn it right back to Mark and Ron then to talk about the importance of being able to weaponize holistic analysis in real time. Because at that moment, if you can get to that intersection, then what happens is the media, while they're debating it before they vote on it, gets to say, well, what about this issue over here that you haven't talked about? What about this different timeline that you say you run it out 10 years, but look what happens if you run it out 20 years? So that they now can have a conversation, perhaps, that the consumers and the public can get their arms around.
Well, I just want to say this has been a great discussion, and Bart, since we've worked a lot, picking up on your point, maybe in this whole mindset issue and all the issues that Gabe has raised and Ron and Gail, maybe we need to go back and make a demonstration back to 1950, because, in 1954, which came out of World War II, we put in a premium tax exclusion. And that led to a lot of things like Medicare, Medicaid. And it's not that those systems aren't needed and useful. It's not that they're not set up properly with the disconnect subsidy need. They're not managed. They don't have a control cycle. So those are some of my thoughts, that somehow we need to put this all together and explain it to people. Why is the system working so poorly, as Jim talks about? Because we've done all these things that basically violate basic principles of actuarial science, of economics, of medicine, of accounting, that if you don't fix those problems, you can't just keep adding when you have, if you don't know how to tackle and block, your football team's not going to be good.
It seems to me that one of the things that's happening in our legislative and policymaking process is we're not really seeking information to enlighten our decision making. We're selectively using information to make our point and trying to win the day. So, the big global challenge here before us is, how do we sort of break that mindset and start getting a constituency for seeking information on a holistic basis, keep using that word, but to understand what our decisions are likely to lead to, both what we're intending them to do, but also the things that are probably going to happen that we didn't intend. Take that to heart, understand it, create a feedback loop, a management control cycle, like Bob Shapiro would always talk about, to try to then improve our decision-making process genuinely, and try to get the best functioning answer, not just the one that our constituencies are hoping that we will pursue.
On that note, we have a few minutes left here. Give you a chance, if you have a question or a comment you'd like to make, this would be a good time to leap in.
I'll make a comment that crossed my mind on part of the earlier discussion: transparency of costs. My feeling is that while more transparency would be great, and we're starting to head down that road with some government mandates on prices being shown by hospitals and such, it seems to me it's more of a kind of a side effect to the underlying structural problems that we have. We don't. I think we do not have transparency because basically consumers don't demand it. Because as we've discussed, it doesn't really affect them very much. So that's one comment on the transparency. I don't think just getting transparency would materially help solve the problem that we have in that area, although it would be somewhat helpful. It's great discussion today.
Thank you all very, very much for being here. I appreciate it. Please do watch the third program on holistic analysis, and there'll be another webinar after that. And with that, I'll turn it back to Mark and Ron.
Yeah, thank you very much all for attending. And as Jim said, we're going to be talking next time about the modeling. And knowing a lot of you, you'll have all kinds of great comments. Some we may suggestions to change things, and we would welcome that. Ron?
Just thanks to everybody for your participation today. It's a great conversation.